Welcome, everybody, to the 8th CAEP COVID Town Hall. A long couple of months, and we've had some excellent sessions. And tonight, we will have a focus on pediatrics, but we will start with an interview I did earlier today with Dr. Purdy on normalizing deviance in emergency medicine. And so just to remind you, the interview that I did with Dr. Purdy is pre-taped, but the session we'll have on pediatrics is live. So feel free to participate in the chat and send us your questions, and we'll get them answered in real time. And on other news, next week will be our big finale for the COVID-19 town halls, and it'll happen on Wednesday, May 20th. We'll have very special guests, Dr. James Miscolic and Dr. Joanne Liu, and a special feature by the famous band you all know and love, Docs That Rock. James is an award-winning author. He wrote 6 Months in Sudan and On the Ground Floor, and he's working on his 3rd book. And Joanne is the former international president of Médecins Sans Frontières, and she has just finished 2 terms in office and has recently returned to Montreal. So we'll have both special guests live, and you won't want to miss what they have to say. And so I hope that you'll join me and tune in. And after that, we will continue on with virtual town halls, but more in a monthly format. And these will become the CAEP National Grand Rounds. And the summer schedule will feature CAEP speakers from our conference that were unable to give their presentations this year. So do tune in for those. Keep an eye out. The announcements will be coming out soon. And we will continue to feature different topics that are important and relevant to your practice. All right, so onwards. Dr. Purdy is a PGY 5 in emergency medicine at Queen's University. I think she's our first resident on our town halls. And she recently earned her master's in applied anthropology after completing thesis work related to the culture of high-performing teams in trauma care. And so we are going to start with an interview that we did this morning. And without further ado, I'll turn it over to Eve. So our first question for the interview today, Eve, is maybe you could just talk a little bit about yourself. Introduce yourself in terms of your background, what you're doing right now, and your future plans after you finish residency.
Sure. So right now I'm a resident in the FR Emergency Medicine program at Queen's. I'm just in my 5th year, so finishing up everything. In fact, I was supposed to write my oral exam tomorrow, but that's obviously not happening anymore. I have a background specifically in anthropology. So alongside my residency program, I did a master's in applied anthropology, which is basically using anthropologic methods to study real world problems. And I focused my thesis research specifically on trauma teams and the culture of trauma care and how we provide it, specifically how relationships affect our ability to do work well. That framing has really influenced a lot of the way that I practice medicine and has been a fairly significant impact on kind of my training throughout. I never really imagined that my worlds in anthropology and emergency medicine would collide quite as drastically as they have in the last couple of months.
It's super interesting. And will you integrate anthropology into your practice as you go forward after you finish your residency, once you are able to write your exam?
Yes, yeah. I mean, absolutely. So I incorporate it in my day-to-day practice with patients. So anthropology really is at its finest kind of data-supported storytelling. And that's not much different than what we do with patients on a day-to-day basis. We hear their story, we add some data to it, and we translate it into something that our colleagues value in some way. And so I've used just kind of basic skills in anthropology to help me at the bedside with patients. But more than that, I certainly will be looking to apply anthropology to our work and our system. Even right now, we're actually doing a rapid cycle applied ethnography of our department during our response to COVID-19, specifically of the staff involved, to understand what life is like on the front lines. And just as a bit of a disclaimer, in Kingston and the KFMLA area right now, we have essentially 0 cases, and so our study is of how departments change and prepare for a pandemic. We're not yet really in the thick of it, like many of our colleagues are across the country and around the world. So I recognize that I'm kind of speaking from a bit of a place of privilege right now.
Well, I think it's fascinating, and I think it's a good segue into you talking a little bit about your article that you just had published. Maybe you can tell everybody what the article was about, first of all, and where it was published, and give us some details on that.
Sure. So the article that I just wrote is called Normalizing Deviance, and it's an article published on the CMAJ blogs. It starts with a kind of a narrative that, though not based on a single patient, is representative of kind of many patients that I've dealt with during this time. And I outline a pretty simple emergency medicine case, really, an older gentleman who's coming in with a non-STEMI, and reflect a little bit on the fact that his care, which saw him come directly into the emergency department, get the interventions that he needed, and go to the ward in the course of about 2 or 3 hours, is dramatically different than the way that I'm used to caring for patients, in the way that I have come to know what emergency is. I've really grown up in emergency medicine in Canada over the last 9 years, and I just thought that hallway medicine was a part of my job. I describe the story of Mr. Jackson and reflect on the fact that, even just a couple of months ago, it would not have been unusual for me to come back after seeing him to the emergency department 24 hours later for a new shift, and him still be waiting there to go up to the wards in a stretcher. The response and the kind of overwhelming preparation of our healthcare system to receive COVID-19 patients in our area has meant that right now we have an empty hospital, an empty emergency department, stretchers, which means that we see patients right away, we get them the care that we need. We actually have a little bit of time to chat with them and counsel them. And then they are cared for on the wards, which is where they should be cared for. And that was just a revolutionary experience for me as an emergency medicine resident, which I think speaks to how far we've gotten, that I've gone through my entire training not knowing what emergency medicine looks like without patients in the hallway. The article kind of evolves to talk about the fact that we're seeing a new type of deviance come in, which is practicing emergency medicine without families at the bedside. And in some of the work that we've done, or that I've done speaking with the staff in our department, I've spent time doing about 35 interviews with staff in our department, all the way from porters and housekeepers to our department head. The thing that is just tearing people's hearts out right now, actually, is the fact that families aren't at the bedside for patients. It makes the job harder, but more importantly, it's just awful for patients and their families. And we can't normalize that. Obviously, understanding right now from an infection control perspective, it's necessary, but as soon as we are possibly able, we need to get families back at the bedside.
So you use the word deviance, and I'm just curious, I guess, first of all, why you chose that word, and to relate to both hallway medicine and then this new genre of medicine that we're practicing now. And maybe you can just elaborate a little bit more on that. And are there maybe better solutions, or are we always going to practice with some degree of deviance from your perspective?
So I would love to take credit for the term, the normalization of deviance, but I can't actually. This is a concept that is a bit new to healthcare, but is not new to other industries. So the normalization of deviance is this theory, basically, that ever so slowly we can accept the extremely abnormal. I'm sure that most people have heard of this concept that frogs will die in water that is just slowly, gradually warmed because they get used to it. And then all of a sudden it's at a boiling point and they die, but they never leave the water because it's just slowly getting warmer and warmer. And I guess that basically is the concept of normalization of deviance, that if every day something is just a little bit more abnormal, then we don't actually doesn't hit us across the face as being something that's extremely inhumane or inappropriate. And it actually sometimes takes such a stark contrast of what we've experienced over the last couple of months to actually realize how far we've come from the ideals that we probably would like to live up to. So there's all types of deviant behaviors. I think, sometimes in the hospital we come to accept deviant personalities, and we just say, oh, that's so-and-so, because they've been in an organization for a long period of time. That's pretty common. We accept kind of deviant behaviors in in ourselves. We maybe cut corners that we don't usually cut. So I think there's all types of ways that we practice deviance. But I think from a systems level perspective, the piece that I've seen the most in this time is hallway medicine.
And and then you refer to a new deviance. So what is that? Because we're not certainly practicing hallway medicine right now.
No, we're not. I mean, so yeah, so I guess deviance would be a word that like is something that we equate with an evil of sorts, I suspect. And the deviance that we're seeing right now is not being able to include families in care. And as much as practicing hallway medicine was a part of my residency, being patient-centered and family-centered is also an important part of my training, and is something that I totally take to heart as an emergency physician, and feel like I probably haven't been able to do as good a job of during this time. And slowly but surely, that has felt more normal. So in this article that I wrote, I reflect on the first time that I had to communicate with a family on the ramp of our emergency department where our ambulances sit. And I had to go out and tell this lady whose husband of 65 years was inside having a heart attack that we were going to look after him, but she couldn't come and visit him. And I didn't really know what that meant for this couple. Was he ever going to leave the hospital? How long was he going to be in there for? I doubted that they would be able to figure out how to use FaceTime to communicate. And it really, really bothered me. When I went back into the emergency department, I just felt totally weighed down by this interaction. But, I've probably done that dozens or, hundreds of times since. And it bothers me a little less each time. And that is very troublesome, because it is a sign that kind of emotional piece that I think drives us towards finding a better answer is slowly disappearing, and we can't let that happen.
Yeah, I think you make a great point. So, I mean, on that note, how do you have any solutions, or have you thought about how we might manage this new normal going forward without allowing the normalization of deviance to seep in?
Yeah, so specifically when it comes to families, I think there's a couple of potential solutions. And again, this would require thoughts from people who are a lot smarter than I am, because I recognize that the risk of COVID is very real and is not something that we can sacrifice. But I do wonder if for certain patients, families need to be recognized as a part of the care team. So the people that I'm thinking of are those that are particularly vulnerable. So right now we are allowed, pediatric patients are allowed one parent. A part of me wonders whether our older adults who are at risk for delirium and who require increased help with bedside care should also be considered as people who have family members who are a part of the care team. Of course, that comes with risks, and probably risks that I don't understand, but are worth us thinking about and continuing to talk about as a system, and may change a little bit based on what local prevalence is and what the realities of COVID are in your certain area. So I'm not suggesting that we bring families back into hospitals. I don't think that's right, and that is not any expertise that I have. But I do think that we need to keep patients' and families' voices at the center of this as we are making these decisions thoughtfully. So one option would actually be to have patient and family representatives on the committees that are making these types of decisions, and actually amplifying their voice in and amongst the decision making. So that would be one option. Another option would actually be to think about who are the people in our system that are available right now? Because part of what prevents us from, I think, really engaging fully with patients right now is patients' families right now is the extra time that it takes to contact them. So sometimes it's 2 or 3 extra phone calls on top of already looking after these patients. So are there ways that we could involve medical students or nursing students in systematically giving updates to families or being involved in giving updates to families. And then, of course, there's some technologic solutions that we could invest in as hospitals and departments to help a bit as well. But I think it's an opportunity to get creative. And I think if we keep patients and families' voices at the center of this discussion, we'll probably find a way. But we can't lose sight of that.
That's wonderful. That's very well thought through, and I hope that there's going to be opportunities for us to employ your suggestions, and I'll look forward to your next article on that topic. Did you have anything else you'd like to add or say that we haven't covered?
I think that the one of the key concepts around the normalization of deviance is that it's not related to bad people or to people who are not wanting to do their job well. It's just a slow creep. One of the concerns that I had while I was writing this article was, am I going to seem like I'm ungrateful or have not thought that my training is excellent? And that is not the case at all. I think my training and my experience in the healthcare system has been fantastic. And I've been surrounded by people who are working their hardest to do their best and take care for patients, just kind of despite the circumstances. And it's not that deviance has kind of a negative connotation, but the idea is that it's actually just normal, good, well-intentioned people can land and find themselves in a situation that is so abnormal because we allow a little bit of creep day in and day out. And so it happens, this happens to us all, but now is this opportunity where we get to stop and reflect and think, wait a second, this is not right. And we'll have to figure out as a system how we sort through that. And it's made me think a little bit about the framework that I used for my thesis, actually, which was this concept called relational coordination. And the way that high functioning organizations get work done efficiently is when they've got shared goals, shared knowledge, and mutual respect. And I think that this episode that we're having in healthcare right now with COVID-19 is really sharpening and aligning this concept of shared goals, shared knowledge, and mutual respect between parts of the organization that didn't really have that before. And I hope that we can find a way to continue to capitalize on these really deep connections that have been made during this time to move forward.
That's very well said. It's like you rehearsed that. No, I really mean that. No, it's very insightful, and I indeed hope that this time is kind of a disruptor in a way. As you said, we can see this normalization of deviance that's come into play that we didn't maybe see before, and now we can be jarred awake and hopefully make some change. So listen, thank you so much, and it's been a pleasure, and I'm sure everybody in our CAEP viewership audience will have enjoyed that. And if they have additional questions, they can always send them our way and we'll get them to you. And we have a forum that we entertain questions on and we can post replies to. So we'll do that. So thank you so much, Eve.
Absolutely. More than happy to chat.
Thank you. Have a great day. Bye.
Yeah, thanks. Bye.
So thank you again so much, Dr. Purdy, for that very insightful interview. And if anybody in the audience has questions, they're welcome to post them in our chat. We have a resource room on the CAEP website for the town halls, and Dr. Purdy will check that and see if there's anybody who wants to get in touch or otherwise, and you can do it through that forum. So on to the next part of the town hall. We have Dr. Suzanne Vaillancourt and Dr. Fuad Alnaji. Dr. Suzanne Vaillancourt and I went to medical school together at the University of Calgary, and we both ended up here in Montreal. So she is the Associate Director of the Montreal Children's Hospital Department of Pediatric Emergency Medicine, and she's an Assistant Professor at the McGill University Health Centers. Dr. Fuad Alnaji is a pediatric emergency and critical care medical physician at the Children's Hospital of Eastern Ontario in Ottawa. He is an assistant professor of pediatrics and emergency medicine at the University of Ottawa, and he's a transport medicine physician at Orange Transport, which is the Ontario Provincial Critical Care Transport Service, and he also serves as the acting pediatric medical director. So again, please participate in the chat, and I will turn it over to Suzanne.
Thank you very much for the introduction. I'm just going to set up my view here. Hopefully everybody can see the slides. My name is Suzanne Vaillancourt, as Kristen said. I work at the Montreal Children's Hospital, and I'm very happy to share a perspective from the little people and in representing pediatrics this evening. I'm going to speak probably for about 15 minutes or so, and then Fuad is going to speak as well. We'll try and cover different topics in pediatrics, make it very practical. We welcome any questions. I'd start with saying that my disclosure, I am an emerge physician. I also am a mother of 4 kids. What I'm not is an expert in infectious disease, epidemiology, rheumatology. Everybody right now is doing their best to keep up with the rapidly changing world of COVID. Articles are getting published very quickly. So what I present today might be a little bit different tomorrow, but hopefully you'll have a good idea of what's happening in the pediatric world. I am also an expert on the use of subjunctive in French, if anybody has any questions, because I've been promoted to director of homeschooling recently in my family. So some topics that we want to address. Children are less likely to be infected with COVID than adults, and we'll give you some of the stats on that. I'm sure you've been seeing that in your own practices. I want to talk a little bit about transmission and what we know in pediatrics about transmission. It's important as we move forward and we look at possibly coming out of confinement and what does that mean for your patient population. How do kids present? I'm going to touch a little bit on COVID TOEs and the mysterious inflammatory syndrome. I won't say too much about it because Fuad has some excellent cases that he's gathered from other countries in the world that have seen more of this. So we'll let him discuss a little bit more about that, but I'll give you a little taster so that you'll be ready to ask him questions about that. And how do we manage kids with COVID? And then something that might be a little bit more controversial and maybe the parent side of you is wondering about is, should we let our kids out of confinement? So kids, you hear this all the time from pediatricians, are not little adults. And it's something that's sort of our mantra, and that we treat them differently and things present differently. But I would say that our experience thus far with COVID specifically has shown us that pediatrics is presenting very, very different than it is in the adult world. So what I mean by that is really the incidence. So if you look at 150,000 positive patients in the US, pediatric patients, less than 2% of them were children. In the Quebec data, which we have, and Quebec is right now considered the epicenter of Canada, even here where we have a significant number of cases, less than 3% of our cases are under 18 years old. So you might say, okay, well, that's just because we're not screening, which there's very valid a point with that we don't know. You know, you do fractions with your kids now, you don't know what the denominator is. So we don't necessarily know how many kids are positive because we're only screening the kids that we see. There was a small study out of the city of Vaud, which is in northern Italy, which obviously is an epicenter as well. And they screened 70% of their population, and none of their kids under 10 years old were positive, despite having about a 2.5 positive rate in the community. So a little bit of food for thought, but what we can say that we've seen so far is that it's just not the same disease in pediatrics and adults. So it's a little bit like comparing apples and oranges in terms of what we see and how sick the kids get. So if you look at here, this is data from the United States, and if you see that generally, if you look at the kids under 18, you're seeing about a 0.4% rate of hospitalization. So again, being in Montreal, I can tell you the Quebec data. We have 2 pediatric hospitals in the city of Montreal. We've had, this is probably updated up to about a week ago, we had 19 admissions for COVID positive kids. However, the majority of those were admitted for other reasons. They swallowed a coin, well, probably not a coin, but they swallowed something that had to come out by a G-scope. They had a urinary tract infection. And because of the screening we did, we found that they were COVID positive, but they weren't coming in specifically for COVID symptoms. So that's 19 admissions compared to over 500 admissions that we've had in the pediatric hospitals this year alone from influenza and RSV. So it's very different in terms of the débordé, the filling up the hospitals that we're seeing in the pediatric side of things. So I think everybody probably agrees on that because that's the the data that we've seen so far. So the question comes down to, do kids transmit it? And that's a big question on everybody's mind as we move forward and open up things and people worry about their own health as parents or being in contact with grandparents and other people with medical problems. So unlike influenza, where kids are a hotbed of spreading, it doesn't seem so far that kids are spreading it. In fact, kids that are getting it are most likely getting it from adults in their household. So many of you might have heard of the most famous non-transmitting skier that ever existed. This is a boy that got COVID from a British citizen, I believe. I think the British citizen got it in Singapore, then came skiing in the Alps in France, shared a chalet with this boy who got COVID. And then after the fact, he was in contact, unbeknownst that he had COVID, with over 170 people, adults and children. And nobody was infected by him, despite close contacts. And interestingly for this is that he also was positive for influenza and the coronavirus, the common cold, not the SARS. And his siblings both were positive for influenza and the common cold virus, but not for COVID-19. So that's one boy, but unfortunately in this time when everything's changing so quickly, we don't have a lot of data, but from him, we can see that there was no transmission to his contacts. Then the Australians who are back in school did a non-peer-reviewed investigation, and most of the research right now, or not most of it, many of the research right now hasn't had the chance to be completely peer-reviewed. But in this case, there was 18 individuals, 9 students, 9 staff from 15 schools who were all COVID positive. They were in contact with over 800 people, 735 students, 128 staff, and no teacher or staff member contracted COVID from those kids. 2 children may have got it from initial contact in school, but the take home from that is from this study, obviously the authors acknowledge further surveillance is needed, none of the kids gave it to their teachers. We haven't done any studies in Canada looking at schools. Most of our schools are off, with the exception of Quebec, where some of them have started back. But interestingly, here in Montreal, there was a large outbreak in a very ultra-Orthodox Jewish community in around Montreal. It was linked to 2 large weddings and probably some travel back and forth to New York initially. This is when the outbreak started in Montreal. And usually these families, the ultra-Orthodox Jewish families, tend to have many children, and they have their children extensively in contact with other children. And although there was many adults that got very ill, many adults got very ill, no children. There was no pediatric cases that were sick from that. We didn't screen them all, but the ones that were screened within a family where the adults were sick turned out to be negative. So that's just our local experience from a very small outbreak that we had. So clinical characteristics, I'll just touch on this mildly, and Fuad will give you some cases. Many of the kids are fine. They look like the girl at the top of the slide with their 2 thumbs up. You wouldn't know that they had COVID. Some of the kids have mild symptoms, fever, dry cough, runny nose. And then we're seeing a little bit more of the gastrointestinal symptoms, vomiting, diarrhea, things like that. Now, realize now that at least in the pediatric emerge, we're not really testing for many other things right now. We're really just testing for COVID or in terms of infectious symptoms. So we don't know, if you don't test for something, you don't know. So whether all these gastro symptoms that we're having are truly related to COVID was unclear. But what we are seeing is more mild symptoms, either respiratory or gastrointestinal. It is worth noting that, that these cases here in this study where they published, the 11 published studies that they looked at with clinical features of about 640 pediatric cases, 8% were asymptomatic and the rest presented with the similar symptoms as the previous slide. Obviously from this, you see that the rate of asymptomatic is extremely low compared to those presenting with symptoms. But these were kids that were screened, either coming into the hospital or seeking healthcare for other reasons. So that's not really indicative of the general population. So then a lot of people say, well, should I worry about infants? Because when it comes to influenza and RSV, we really seem to see that our infants, our babies, take a very, very hard hit from those viruses. So the CDC reported on cases 2,500 in February and March, and of the 95 patients that hospitalized, over 60% of them were less than a year. So you wonder, are infants at a higher rate of hospitalization? That wouldn't be that surprising given that they're at a higher rate of hospitalization from influenza and RSV as well. Though, like many things in COVID, the second study that came out looking at kids that actually were sicker, so admitted to the hospital, then actually went on to be admitted to the PICU, pediatric intensive care unit. And those kids were much older. They were more in the older age group, in the teens. 13 was the median age. And of those that got quite sick, so sick enough to be in a PICU, 83% of them had significant pre-existing comorbidities. So these were not, and many of those were respiratory comorbidities. Several of these kids had trachs, so they had quite significant comorbidities. And the 2 deaths that they did have in the States in the PICU from the study that was published in JAMA were both with pre-existing comorbidities. So really what that speaks to is maybe the infants, the younger kids, are getting hospitalized a little bit more. They don't seem to necessarily be getting sicker like we do see with influenza and RSV, and that the sicker kids may be more in the older age group. And when Fuad discusses some of the complications or presentations that we're seeing of COVID right now, then we can probably address this a little bit more. I won't really touch on this other than there'll be a quiz at the end if anybody can memorize this slide. But essentially what this is just to say is people are saying, well, why are kids getting less sick? Is that they don't have the same cytokine release, which is the first picture that you might remember back from medical school. And the other question is the expression of the ACE2 receptor. So the point from this is just they're looking into why our kids are not getting less sick. That might be helpful to help plan for treatment for the adults, but for right now, these are hypotheses of why kids are not getting less sick. So I put here, what is COVID toast? Because the first time I heard about this, the physician I was speaking with was wearing an N95, and I thought they said, have you heard about COVID toast? And I felt quite stupid. I had no idea what they were talking about when they said COVID toast. But later on, I realized that the muffled sound from the N95, they were actually saying COVID toes. This is something, there's a link here that has excellent pictures out of Spain, where they've seen quite a few of this, a really good dermatological atlas of all the different presentations. We have seen this at the kids we've seen have been very well, but this is something that that we are starting to see. But 20% of, according to the Spanish, they're seeing COVID patients have some sort of rash, this frostbite lesion. Some of them look like varicella. The virus has been shown to affect the smaller vessels, so it's not surprising that we're seeing sort of more of this vasculitic picture. But it's just something to keep in your mind. And again, we'll talk about a few cases of that a little bit later, but it is actually COVID toes and not COVID toast. And then the mysterious inflammatory syndrome, again, I'll just touch on this. Fuad will give you some good cases to walk through. So it's mysterious maybe in the sense that we're seeing variations of a typical Kawasaki disease. So we're seeing more atypical Kawasaki disease in terms of not meeting the strict criteria and the age range being a little bit different. We're seeing Kawasaki disease that seems to get more shocky, which we don't usually see in Kawasaki, and then more sort of toxic shock syndrome. So the largest study, and I say that a little bit facetiously because there was only 8 children, but that's what's sort of the norm in COVID pediatrics right now, in the Lancet, was out of the UK. And basically these were kids from 4 to 14 years old, and they presented over a 10-day period. So they saw 8 kids. Normally in this center in the UK, they'd see about 1 to 2 cases of Kawasaki per week. So definitely more than double that they normally see. And they presented with somewhat similar presentation: fever, rash, conjunctivitis, GI symptoms, which we don't usually see as much with Kawasaki, and then myocardial involvement, and then some shock would be. So a little crossover. 5 out of the 8 were male, and 6 of the 8 were Afro-Caribbean descent. It seems to be too that it affects the children. The average age was more around 11 years old. And of these kids, of the 8 kids, 1 patient ended up dying from refractory shock. 7 of them were quite sick. They were on mechanical ventilation. And 1 patient developed a coronary aneurysm, which we do see in Kawasaki's. All of them received IVIG and antibiotics, and 5 were given high-dose ASA. So at the time, the question was, what's the role of COVID? Because 2 of the 8 children initially were tested, only 2 of the 8 children initially tested positive. However, now they added an addendum to their study, and they went back and looked at the antibodies, and subsequently all 8 tested positive for antibodies. Although initially their initial screen swab negative antibodies. So the Canadian Pediatric Surveillance Program is currently going on for this. In Montreal, we've had 7 questionable cases, only 1 that had mild shock. It seems to be a lot of the data, which Fuad will address, and some interesting cases are coming out of Europe. It seems to be more in Europe and the Northeastern United States. as well, but it's something that we'll discuss the management with in the second presentation, but something that you need to be thinking of. But the vast majority of time to treating COVID patients is quite straightforward. There was a question initially about concern about ibuprofen, that in terms of that being a reason not to give ibuprofen to kids that you were questioning COVID. That has not been founded, and you can give, there's a lot of double negatives there, sorry. You can give ibuprofen to kids that you're suspecting COVID. We do not use antibiotics routinely. Obviously, if you think they have a bacterial infection on top of it, pneumonia on top of it, but the vast majority of kids are not getting sick, but antibiotics are not routine. And blood work, the kids that we're seeing at the Children's Hospital are not routinely getting blood work. We're doing blood work basically based on their clinical picture. If you feel the child looks unwell, then we will do blood work, and we will do similar blood work that we would do in a patient you're doing an infectious workup in terms of your CBC culture, your LFTs, coagulation, and then you'd be sure to add your inflammatory markers. Specifically in COVID, things we're looking at is CRP and ferritin and troponin if there's a cardiac. But your otherwise well-looking kid, we are not routinely doing any blood work on them. So now just to finish up, we get to the more difficult question, the one that maybe is a little bit harder to answer. And that question is, should we let the kids out? Should we let the kids out specifically of confinement? There are kids getting out now, but specifically out of confinement. In some provinces, that means should we let them go back to school? I happen to live in one of the provinces where they're starting that and considering it in Montreal, which is the epicenter. And essentially, it's a very challenging psychological experiment. It's a lot easier to go into lockdown than it is to come out of lockdown. The government, understandably in a pandemic, spent a lot of time telling everybody they needed to stay inside, and there was a lot of secondary fear of the virus, which was understandable for many reasons, but at that time that was developed, and it's very hard to reverse some of that psychologically. Stay inside, stay inside. This is a cartoon that's in French, but it's basically just parents welcoming their son home from school, and clearly they look a little bit petrified of him. So my role, I just wanted to spend the last couple of minutes, is just talking about how I feel about it in terms of as a pediatrician, and try and keep my mother of 4 boys hat differently, but more the effects as a pediatrician. So in Quebec alone, if you discuss the negative effects of confinement, there are quite a few for children. There's quite a few negative effects of confinement because they're not getting sick with it. So for them, the benefits of staying inside are really to protect other people, and that's a valid concern. But for them specifically, if you advocate for children, there's a lot more negative. So for example, in Quebec, over 240,000 kids get breakfast at school. We're really concerned about the risk of developmental delay. 2 scenarios for this are that people are not seeing doctors, they're seeing them by telemedicine, a little bit more challenging developmental delay. Telemedicine. Teachers are an excellent source of picking up on developmental delay and learning issues that are not being picked up on kids. A big concern about missing vaccines. In Quebec, the CLSCs give the vaccines. Many of them are not giving them. We have a big concern of the risk of pneumococcal and meningococcal vaccines specifically. These are fatal, can be very fatal. It's fatal, can't be very fatal, fatal in the first year of life, especially. So kids that are missing out on those routine vaccines, either the parents aren't able to get them or there's a fear of going into a hospital or a clinic. There's a risk, that's very real for marginalized kids of domestic violence. A lot of parents have lost their money, have lost their jobs, and that risk and stress goes up significantly in kids that were already in a vulnerable situation. And as pediatricians, that frightens us very, very much where these kids are right now. Mental health, specifically for teenagers, but any kids. Some of it's more fear for kids of the masks and the virus. For teenagers, it's more anxiety or depression, lack of social interaction, concern about the educational gap. Many kids are lucky enough to have access to computers at home to get education, but the longer confinement goes on, the gap widens in terms of what some kids are being offered educationally and what others are being offered. And that is years catch up to be done. And then the fear of presenting to the hospital. I unfortunately did have a child die who probably could have been prevented death because the parents presented quite late. It had nothing to do with COVID, but they had a very, very strong fear of coming to the hospital or felt that it would be a risk. So it's a real fear for a lot of people. I spend a lot of time telling them that, at least on the pediatric side, I know it's different on the adult side, but it's probably one of the safest places that you can be right now in terms of your risk of getting the disease. The infection control is excellent, but it's a real fear out there. There's also the negative effects of your hair. For some people, that might be a little bit higher up on the list, but Mom, we need haircuts, I'm dad. And then the positive effects of letting kids out of confinement. So this is, in my mind, and this is my opinion, but I see both sides of it, but I feel as a pediatrician that most summer activities take place outside. There's a lot of benefits of sports and camps. They're run by people that are not at risk. Most people that run camps are under 25 or 30, not all, but many. The pediatric hospitals are not overwhelmed at all. If your child was to get sick now, you will get seen very, very quickly, and that will most likely not be the case in the fall. Our volumes go up significantly, just as I'm sure everybody that does primary care goes up significantly with respiratory viruses we wait until the fall. So letting all the kids out in the fall, to me, does not make sense. We will be overwhelmed, most likely, with possibly more cases of coronavirus, but definitely cases of influenza and RSV. The question of herd immunity is a little bit of a difficult one. It's not really clear whether kids will contribute to it. They may not. We don't know if people are getting natural immunity. We're not seeing, it's a big debate. I do not claim to be a immunity expert or infectious disease expert. Whether the role that kids play in passing on immunity, especially if they're asymptomatic. All the testing and focus has been on symptomatic people, so it's really hard to make a clear statement about what's happening with immunity. I mean, anecdotally, you could say that we're not seeing a lot of people that have been infected coming back again with a second episode of COVID, I guess you would say. So you could deduce maybe from that there's some immunity getting out there. I don't think that herd immunity is the reason to let kids out and send them back to school necessarily, but it could be a positive side effect. It could be a positive spin-off from having them out. But I don't know that the reason to put them back either into schools or to camps should be to have them have herd immunity. You do need a significant proportion of the population to have herd immunity. Kids may contribute, they may not, but they don't seem to be getting sick. So if they could help, there's probably not a big hindrance in terms of letting them out of confinement. There is controversy, very strong controversy over school. There was a study that from the UK, from the Lancet of Child and Adolescent Health, that said, we know from previous studies that school closures are likely to have the greatest effect if the virus has low transmissibility and attack rates are higher in children. This is the opposite of COVID. And essentially, people that are against school closures say that it really doesn't make sense to close the schools. There's been 16 studies of recent outbreaks of coronavirus, including the SARS in 2003. And these studies were done in China, Hong Kong, and Singapore, and found that school closures did not help control the epidemic. Now, obviously, they have very different ability to trace and track cases, so this could be a biased study, but they didn't see any change. And in fact, data on the benefit of school closures is limited, but we know that their impact is likely only to be small compared with other infection control measures, such as case isolation. So that's sort of the flip side of wanting to open the schools. If we do open the schools, what do we do with kids with asthma? Fuad will talk about the management of asthma. The most current updates from the pediatric side are really that kids that currently have asthma just continue with their current asthma treatment. If they are on steroids as part of their maintenance treatment, you can continue that. And there's no really evidence thus far that they're at increased risk. There is, of course, the theoretical possibility that kids with asthma will have exacerbations related to COVID like they do with any other virus, but we also send those kids to school normally. Interestingly, we have not seen, at least at the Children's Hospital, I don't know where all our asthmatics are. Obviously, they're getting less viruses, but kids are not presenting with severe asthma attacks currently right now. So just to finish up, a couple of take-home points before I pass it over to Fuad to discuss a little bit more about COVID. So as you're seeing probably in your practices, only a small proportion of COVID cases are pediatric. They may have a limited role in spreading infection. Nothing is definitive, but thus far it's pointing more towards that they have a limited role. Mostly the presentations are mild, asymptomatic, some respiratory GI symptoms. Fuad will discuss a little bit more the role of COVID in this hyperinflammatory syndrome. For the most part, management is supportive for COVID cases. And the thoughts on letting the kids out of confinement, you really have to really weigh in the negative effects of confinement on kids versus the positive effects of them getting out and the benefits. Obviously, understanding that if they are living in a family that has medically vulnerable people or living with older people, that's a very different situation. But I really think the take home should be to isolate the vulnerable and let the kids out because they're not getting sick. That's the end of my proportion. I will try and unshare my screen here. And then I'll pass it over to Fuad, and then we can answer any questions.
Thank you, Suzanne, for a good presentation there. And thanks for CAEP for the invite. So I'm going to follow up on what Suzanne has presented earlier. I work in Ottawa and I work in the ICU and emergency medicine. I also do a bit of transport. I have no conflict of interest apart from that I work at the University of Ottawa as well as at Orange Transport. And as Suzanne mentioned, by no means an expert on COVID. I've read a lot, and there's so much information out there. It's really hard to keep up. But as far as I know, this information is up to date as of yesterday. So the objectives of today's presentation, I hope after attending this session, you'll be able to outline the pediatric respiratory support for patients with suspected or confirmed COVID-19, list the approach of pediatric cardiac arrest in the age of COVID-19, describe some post-infectious SARS-CoV-2 pediatric presentations, and discuss some indirect health effects of COVID-19 on pediatric patients. Just to follow up on what Suzanne was talking about why are kids less affected? It's hard really to figure this out, and is it really that kids are affected less often? Is it possible that there's a higher false negative rates from the swabs? Really hard to know. We know in the subset of in Toronto tested about 2,300 kids, and they only had a 0.6% positive rate, 15 swabs only out of 2,300. We've seen definitely from anecdotal evidence that in Ottawa that there's a lot of kids that come in with respiratory symptoms with COVID positive parents that test negative. So it's really hard to know whether it's a false negative or read negative or true negative swabs. There's also this discussion of ACE2 receptors. So we know in SARS-CoV-2, the virus probably is optimized for binding to the human receptor ACE2. So do the kids have less ACE2 receptor representation? That's just food for thought. We also know that some of the severe presentations in adults have been linked to a significant degree of inflammation or cytokine storm. Maybe the kids have no cytokine storm, and that's why they have no significant disease burden. As Suzanne mentioned, most kids are asymptomatic or have mild disease. And unlike adults, a lot of them have GI symptoms. And interestingly, some kids also present with severe GI symptoms like severe abdominal pain, even to the degree where they present in a picture of peritonitis requiring laparotomies. There was one study published a couple of days ago, and Suzanne touched on that, by Shekhar Damian. It included 14 PICUs that had positive patients. We had 6 Canadian sites. None of them had any ICU pediatric admissions. And as Suzanne mentioned, most of those kids really had underlying medical conditions. 40% had tracheostomies and were on some form of respiratory support. The other risks were immune suppression in about 23%, whether they're cancer related or not, and 15% were obese. And over 50% of those kids were above the age of 10. So what do I do as an emergency physician with the next child that comes to me with respiratory distress in this age of COVID? Let's go through some common pediatric respiratory presentations, and you'd be surprised to know that there's probably not a big change in how we manage those patients. And these patients present with respiratory symptoms most likely related to some other virus, but this can be COVID-19. Just to touch on those, so for asthma, the overall approach is to avoid aerosolized generating medical procedures or AGNPs. So nebs or nebulizations are considered AGNPs. So for asthma, avoid nebs if possible and use MDIs as much as you can. Give early steroids within the first hour in cases of moderate to severe asthma. In case where you have a child that needs nebs, then use nebs, but consider that as an AGNP. What about croup? Just like asthma, again, early steroids would help in croup management. What about in cases of severe croup where epinephrine nebs are shown to be helpful? If it's severe and that's your only option, then I would say use nebs, but consider it as an AGNP. Some pediatric emergency physicians were trying to get the special access MDI epinephrine. And we have it in Ottawa. They have it in a few pediatric centers. We don't know whether it's as effective as nebs. So more studies are to be done for this. So what I would say is use your nebs if need be. We had a lot of questions about the use of IM epinephrine in severe croup. And there's no evidence that really this makes a difference in severe croup. So I would say if you need it, just use the nebs. What about bronchiolitis? The mainstay for bronchiolitis treatment is supportive therapy. So we suggest avoiding nebulized medications. What about if a kid needs more than low flow oxygen? So high flow oxygen has been used in many settings. And especially in the case of bronchiolitis, it's been shown to decrease need for escalation of therapy. And it uses humidified oxygen of rates of usually over 1 to 2 per kilo per minute of flow. Probably it can increase the rate of aerosolization. We don't know that for sure. But a study by Dr. Mataba out of SickKids showed that in rates over 25 liters per minute, there's increased risk of aerosolization when somebody coughs. So if you're going to use it, but consider it as an AGNP again. What about non-invasive positive pressure ventilation, like CPAP or BiPAP? In kids, we mostly use a nasal piece or nasal CPAP, BiPAP. And some authorities think that a full face, like you see on the picture on the right, may decrease the rate of aerosolization, but we don't know that for sure. But we also know for kids that most kids really would not need any further escalation to intubation if the high flow or CPAP support helps decrease the respiratory distress. So what do you do if you need to intubate a patient? It's probably similar to what you need to do in adults with a few caveats. There's no recommendation for early intubation in patients with suspected or proven COVID in pediatrics. So just like you would do with adults, you make sure that all are protected. We would recommend the use of cuffed ET tubes in those patients. And the most experienced person would intubate. Prepare the medication before going to room, minimize interruption of the vent circuit once you intubate. And all of these, as I said, are not really different than adults. But the overall principle is really do no harm. What about transport? I know, part of the audience here is a lot of emergency physicians that work in rural or centers that don't have tertiary care. So what I would suggest is know what your local transport guidelines are. So we know that most critical care transport entities have um, limitations on the use of high flow or non-invasive support on air transport for adults. And I know for Orange Transport within Ontario, we will not transport anybody on high flow or non-invasive on air transport, whether it was rotor or fixed wing. Some would allow pediatric patients to have those therapies on air, and most would allow them to be used on land transport. So know your local transport guidelines if you need to use those therapies, and plan to transport the patient to a larger center. What about cardiac arrest? We know the most common cause of pediatric cardiac arrest is respiratory. So there's been a lot of discussion about the use of chest compression only in pediatrics and protected codes in kids. So we would suggest, considering the benefits versus harm. So if the kid has a respiratory arrest causing cardiac arrest, you doing chest compression only until you get everybody on board is probably the best thing to do to protect the team. But most kids would improve with bag mask ventilation and chest compressions. Most centers would treat any VSA arriving to the ED as a suspected COVID patient and would suggest using protected codes for those VSAs. Just switching gears here to this SARS-CoV-2 associated pediatric multisystem inflammatory syndrome, which is really a handful to say. So is this really a Kawasaki-like illness? Is this really a refractory vasodilatory shock with a normal cardiac function? Is it cardiogenic shock? Or is it a combo of all the above? Before we move on to discuss a few cases, I'm sure most, if not all of you, are familiar with diagnostic criteria for Kawasaki disease. But just to make sure we know what that is as we move on to the cases. So you can diagnose Kawasaki disease if you have fever for 5 days or more, plus 4 of the following 5 criteria. Bilateral non-puerine conjunctivitis, oral mucous membrane changes, peripheral extremity changes, some sort of a rash, and cervical lymphadenopathy. One of the, I think, good things that happened out of this COVID crisis is a lot of collaborative efforts. A group out of Boston created this international PICU COVID-19 collaborative with over 300 ICU physicians for pediatrics in over 6 continents. And we have met once or twice a week since then to share local experiences and what's happening with patients overall. So all those cases that I'm going to present are coming from this COVID collaborative and are all real cases that happened in Europe. So case 1. This came out of, I think, Spain. A 6-month-old presented with a 5-day history of high fever, developed a rash, had bilateral conjunctival injection, cervical lymphadenopathy. They had stable vital signs, so they fulfilled the criteria for Kawasaki disease. They had normal systolic function on the echo, and later on developed severe coronary dilatation. They were SARS-CoV-2 negative, but presented in this era of SARS-CoV-2. They had high D-dimer, they had high platelets as commonly seen with Kawasaki disease, and they had normal troponin levels. They were admitted to the floor and received the standard Kawasaki therapy. In contrast with this second case here, a 5-year-old who presents with 6 days history of fever. They had some diarrhea and abdominal pain. They had a strawberry tongue, rash, conjunctivitis, cervical lymphadenopathy, and also had stable vital signs. Their swabs for SARS-CoV-2 were positive, and they had a normal systolic function on the echo, and initially had a normal coronary anatomy. They had high D-dimer, normal troponin, and like a lot of the COVID patients, they had low platelets. This patient went on to get IVIG and developed and did not develop any abnormal coronaries. So this is a SARS-CoV-2 related typical Kawasaki disease. Case 3 was an 11-year-old kid who developed fever for 2 days, had some GI symptoms with diarrhea and abdominal pain, had also some rash, and developed hypotension, had no problems with their lungs, and their swabs for SARS-CoV-2 were positive. The echo showed severe LV dysfunction and normal coronaries. And just like a lot of the other kids with SARS-CoV-2, they had high D-dimers, low platelets, but this kid also had high troponin. This kid received immunoglobulins and some other immunosuppressive or immune modulating therapies and recovered their cardiac function within 1 week. So this case showcases the SARS-CoV-2 related cardiogenic shock. And the fourth case is a 10-year-old who was previously healthy, who presented with 7-day history of fever, abdominal pain, and then had this refractory vasoplegic shock. They also had ARDS. They had normal cardiac function on echo and required a lot of vasopressive therapy to support them. And had high D-dimer, high troponin, and a normal platelet level. Interestingly, this kid did not fulfill the criteria for Kawasaki disease. And this kid, interestingly, developed coronary dilatation 1 week later. So this case is a SARS-CoV-2 related vasodilatory shock with a KD twist. So it seems like we have a lot of different varieties of those patients, some in combination, some local toxic shock, some Kawasaki, and some both. So is this really an infectious phenomena or a post-infectious phenomena? And as Suzanne presented earlier in that 8-case series, I heard a presentation by the same authors, and they had about 38 cases now. And they mentioned that 46% of those patients were coming of Black ethnicity. Unlike the usual Kawasaki, usually is more of an Asian descent. And interestingly, the group has reached out to people in Asia, and there was no increase rates of Kawasaki disease, even in Japan, which had usually an increased number of Kawasaki disease. And this was seen mainly in Europe and in Eastern US. So is this related to the SARS-CoV-2 European variant, maybe? Did the virus mutate? We don't know. I think time will tell. And some of those cases had negative swabs, but later on had antibody testing and showed positive antibodies. The interesting thing with antibodies is the testing is not yet very accurate. We know that there's probably cross-reactivity with other coronaviruses. And as far as I know, in Canada, there's no reliable test for antibodies that's Health Canada approved and available for people to use. But we know in all those cases, they had persistent fever. They had inflammation causing neutrophilia, high CRP and high ferritin, and most, if not all, had lymphopenia. And they all had either single or multi-organ involvement. So how do we deal with those? How do we treat them? If they present like Kawasaki and they fulfill the criteria for Kawasaki, treat like Kawasaki disease. But most of the time, treat what you see. If somebody comes in warm shock, you treat the warm shock with vasopressors. If somebody comes in with cold shock and signs of decreased cardiac function, treat them with inotropes and other supportive therapy. The case definition came out of the UK about, I think, 10 days or 2 weeks ago. And I'll have a link in the chat box there for all those. And this came out of the Royal College of Pediatrics and Child Health. So if you want to look at that, it's going to be in the notes. What about COVID toes? As Suzanne mentioned, this is likely a post-infectious phenomenon. It may be related to vasculitis, vasculopathy, or some sort of microthrombi occlusion. We don't know what to do with those patients, but we know that almost all get better on their own. Some centers would recommend doing a lot of blood testing, referring to dermatology or rheumatology, and some centers will say supportive therapy and follow as an outpatient. So follow your local guidelines, but we know that all of those will get better on their own. Another really important thing is to talk about the indirect health effects of COVID. We know that medical conditions other than COVID-19 may become emergent or urgent, and families should never be discouraged from seeking medical care in these situations. Italy reported about a 75% drop in PEDS emerge department visits during this epidemic. And reports from Italy and the US showcase delayed presentations of pediatric patients due to the fears of contracting SARS-CoV-2. A report from the US outlined 5 patients with leukemia that presented late in either cardiac arrest or were critically ill and required intubation on their emerge presentation. 2 of those 5 patients ultimately died. And the sad part is that these cases of leukemia carry a cure rate of 70 to 95%. In Italy, in 5 hospitals within a week, 12 cases had significant morbidity due to delayed access were documented. And these cases included severe decay, shock related to a lot of vomiting from pyloric stenosis, sepsis due to pyelonephritis, and late new cancer diagnoses, including 1 patient with leukemia who died ultimately. In total, 4 out of 12 died, though none had COVID-19. So in summary, most kids do not develop COVID-19 or are asymptomatic. For respiratory support, know what you can and cannot provide. Always think of protected go blues. SARS-CoV-2 associated pediatric systematic multisystem inflammatory syndrome probably is more than one entity, and indirect health effects from COVID-19 on kids is likely worse than the virus itself. Thank you.
Thank you so much, Fuad and Suzanne. I just want to go into the questions. Super. So can you hear me? Both? And Suzanne, is your mic unmuted?
It's on. I'm on now. It's unmuted now.
So a few questions. Have you used procalcitonin to diagnose bacterial co-infection in the pediatric population as a marker?
We at the Children's don't have access currently to procalcitonin regularly. So we are using more like our regular bacterial infections. We're using more CRP would be the marker that we'd be using, but we don't have regular, turnaround time to get access that it would be clinically useful for procalcitonin.
Yeah,
currently, so we're not.
In Ottawa, where we don't have access to procalcitonin, it's a good test, but unfortunately we don't have it in Ottawa.
Can you comment on the correlation, if any, between COVID and Kawasaki syndrome? I think we've covered that pretty succinctly. Would the higher rate of hospitalization in infants in the one study be explained by fever, septic workup, and observation, or were there other reasons for them being admitted? I think that, Suzanne, it was for you when you were talking about the little babies.
The study where it was a higher rate. My understanding from that study was more for observation as opposed to the septic workup. We have a protocol that we're using for septic workup in the COVID that specifically has to just do more with follow-up to facilitate follow-up for these kids, given the turnaround time for the COVID. But my recollection from that study was more for hydration and more support as opposed to significant interventions, because the kids were not going to the intensive care unit, but rather being hospitalized.
Mm-hmm. Great.
If that answers the question.
Yeah. Fuad, can you comment on fluid resuscitation in peds in shock presentations and decision to move to pressors like epinephrine in inflammatory syndrome?
So, good question. So, this is not different than what we would use use in other non-COVID related shock states. So, we would suggest using the pediatric sepsis guideline recommendations of using fluids, your 40 to 60 per kilo of fluids in somebody who's shocky, then moving on to inotropic or vasopressive support. And whether it's warm or cold shock, again, as we would recommend, using norepinephrine, epinephrine to support those patients after you give your crystalloid boluses.
And Suzanne, do you have anything to add to that?
No, I'd agree. I think the take home from these cases is that you go back to your basic principles, and I think I know that I'm guilty of that in the emergency room. Everything is so COVID focused that sometimes you just forget that it's just regular. There are still regular medicine, and you just have to go back to your basic principles of PALS. It's obviously stressful with the PPEs and the aerosol generating procedures and what you have to wear, but the pediatric patients, the physiology for these cases is very similar. They might, seeing slightly different presentations, but you should still just go back to your basic principles, like Fuad said, and manage the shock as you would normally. Obviously, if you have concern for COVID, taking into account your protection.
Mm-hmm. And so a couple of questions regarding the inflammatory nature of COVID. And one is the relationship between the inflammatory syndrome and COVID-19 causation or correlation at this point?
So as we mentioned, again, we don't know. Again, there's a lot of we don't know in this COVID era, and we're trying to learn by collaboration, and it's likely post-infectious. We said again, maybe it's we have these strong opinions loosely held, so we may change our opinions and say we were completely wrong. It doesn't really make a difference in the way we manage the patients, though. We manage what we see, as Suzanne was mentioning, and if somebody comes in shock, we support their shock state. The specific therapies of immunoglobulins, immune modulations, I think should be left to the experts. And even as an ICU physician, I would not, go to using immune modulation without the consultation probably of infectious disease or rheumatology. And the overall, I think, emergency group, I would say treat what you see, refer to somebody else, and let them support the patient after having some time to think through the problem.
Great. So then, in adults, we're seeing a kind of a hypercoagulation, and even some adults are being put on Fragmin right away as a prophylaxis. And so is anticoagulation, and are there any recommendations, I should say, for anticoagulation in kids with COVID-19? Have you been doing that, or have you seen any increased rate of hypercoagulability?
I know that I don't think we have, but maybe you have a little bit more knowledge from the critical care hat as well. But from my understanding, I mean, definitely not, the children's were not seeing it, but in terms of the hypercoagulable state that you're seeing in the adults, we, at least clinically, don't seem to be seeing that to the best of my knowledge, unless you've had different experience.
Again, learning from the other centers, we definitely see the same coagulopathy, or the profile that we see with high inflammatory markers, high fibrinogen. So they probably are prone to a hypercoagulable state, and the recommendations from a lot of the experts on Kawasaki and rheumatology to say that in those patients they probably would need some sort of anticoagulation. But again, these are cases that are very, very rare, so it's really hard to extrapolate to the rest of the pediatric population from those few cases.
Thank you. Another question about limiting fluid resuscitation, and is this important in these patients? And then I guess kind of to trail on to that, how are you changing your approach to procedural sedation in peds emerge?
I can maybe speak to the fluids again. I think the main worry with fluids and COVID is maybe again you'll have a systemic asthmatic response syndrome. You may be leaky, and you may trigger them to have respiratory problems, and you may need to support them afterwards with non-invasive support or intubation. So increasing your risk that way. Again, that's my understanding. We don't think that again kids would benefit from avoiding a lot of fluids and going to antropes early. But again, we don't know. So we would go back to the basics and keep it simple and just give them fluid. Again, we say 40, 60 per kilo, 40, 60 per kilo, and then start your inotrope. So as you would in other shock state. And I would defer to Suzanne to talk about what they're doing in Montreal with sedation.
Yeah, we do still do quite a bit of procedural sedation. So our emergency room is divided up into essentially a green and a pink in terms of more infectious symptoms and not. But we went back and forth for quite a while trying to balance the use of protective equipment versus the risk when you're doing a procedural sedation. So what we currently do is when we do a procedural sedation is one physician who is managing the sedation and the airway, should there be any issues, is in an N95 in a full with the visor and the gown. And then on the very rare circumstances, I'm just knocking on my desk here, on the very rare circumstances where we do have an airway issue, the plan would be the rest of the team would leave and would put on their N95s to come back in. But we do have one physician who's doing the airway that does go in like that. It's a balance that we came up with. You know, I'm not saying it's the right thing to do, but it's the balance that we came up with, trying to minimize the risk should something go wrong and not wasting PPEs unnecessarily. You know, it's as many people that have worn them, it's hot staying in there. So we're doing it with during the whole sedation, but we're still continuing on our sedations otherwise as usual, except for that recommendation.
Yeah. Good. Well, the last question was just, we've got one more. So it kind of a nice one to tie up the session. And it says the pediatric COVID-19 rates are so low in Canada. Does this not strongly support a return to school path? And I think, Suzanne, you touched on that. So maybe we'll kind of, end on that note and just maybe go back to what you were saying before.
Yeah, I mean, it's a very opinionated topic. I think Quebec is probably, pardon my ignorance on the rest of the country, but as far as I know, is a little bit of the outlier right now. So those that are not in Quebec, we still have poutine, but you can't really get a lot of it right now, but just so you know. But those are not in Quebec. That Montreal is the vast majority of cases are in Montreal, greater Montreal, I should say. And so the schools outside of that greater Montreal area have gone back to school. It was just on Monday, so I don't know that we've had, at least I haven't had enough feedback about how it's going. And then potentially in Montreal or greater Montreal, they will go back on the 25th. So the recommendations from the Quebec Ministry of Health are quite strict in terms of how many kids is a class. In terms of essentially they're sitting at their desk for most of the day. Many parents feel it's not really going to be school. It's going to be a glorified daycare. Some feel that it's like putting your child in some sort of prison. There's very, very different remarks about it. I personally feel that.
We lost you. You froze. Oh no. Hold on to that thought. Hold on, Suzanne, we lost you.
I'm here. So I think she was clear in her message at the end. So
yes, I think Suzanne, she was clear. There you go. We lost you for a second.
Oh, sorry. I said, I don't know what part you lost me. It was all really good stuff. You missed it all. It's great. No, I was just going to say, as we move more towards the end of the school year, I strongly support at least opening up camps and day programs, because I think getting the kids outside, the risk is a lot less. I really appreciate teachers' concerns that if they're not given adequate guidance and protection, that it's very stressful for them, especially if you're living in a situation where you may have an illness. So there's a lot of factors to balance in terms of, you can never look at things one-sided, but in terms of the kids, I don't see any risk for the kids going back. Obviously, it's not that simple for other people in the school other than the kids, but as a pediatric standpoint, I definitely advocate for it. And coupled onto that, I even more strongly advocate for them getting let out into summer camps, and maybe miss that part, but just for the reasons of, getting the virus is less likely when you're outside and it's run by younger people. And I have a huge concern as a pediatrician that if we keep kids in for too long, that we will have a huge problem on our hand in the fall when we are not overwhelmed right now, at least at the Children's Hospital. It's longer to see a child because of all the protective things we have to do, but our volumes, just like what Fuad said, in Italy, our volumes are down probably about 80%. So it will go up, and if they go up in the fall when all the kids are let out, I think we will lose, have kids that are suffer unnecessarily just because of a lack of resources, because we will very likely be overwhelmed.
It's an interesting, it really does put into perspective this conundrum that we find ourselves in, people making these very personal and professional decisions. So I think your advice is wise, and certainly I haven't thought that far ahead, but you make a good point.
Yeah, it's a tough decision, and I think there's many different parts of society we have to take into account. I just feel as pediatricians we need to advocate for the kids. And I just worry that we'll look back if we don't let them out in 6 to 9 months and feel that we, as Fuad sort of alluded to, we've done more harm than, possibly more harm than good by keeping them in terms of the kids. Obviously that's not an isolated decision, and the effect on other parts of society, we have to take that into account. But I think as each group tries to advocate for the ones that they support, and so we're just trying to get out the pediatric voice, because they're not so good at writing articles and getting on the news themselves. So somebody has to do it for them.
Well, thank you, being the voice for the little people.
Yeah. And it's not just because I want my kids out of the house. I mean, that
thought had crossed my mind.
Two of them wouldn't go back anyway. So I can understand.
So listen, Fuad and Suzanne, I just invite you to stay on, but I'm going to tie up the end of this session, and I want to thank everybody for joining in. I hear from our office staff, Christina Bova, that this was a resounding success. We had a lot of people join tonight. Obviously, a lot of people are interested in this topic area, probably personally and professionally. So thank you so much. And I'll just give one last plug for our session next week, when we will host Dr. Miskalik and Dr. Joanne Liu. And they will wrap up our 9th and final COVID town hall, and then we'll move on to national ground rounds. And so please, please, please tune in. And until then, stay safe, be well, and thank you so much, and have a great evening. Bye.